Okay, so you can go on to the next slide and my disclosures. And next slide. Okay, so in the next 15 minutes or so, we'll be reviewing the common arthritic conditions that can affect the foot and ankle. And I've concluded more things than just osteoarthritis, because kind of us as imagers, we see everything that comes through. And I think the different arthropathies all need research. There's no great treatment options for anything. So I think it's great that we review the imaging appearance of all of them. And we'll discuss the role of advanced imaging modalities in the diagnosis of arthritis. Next. Radiography certainly remains the first line imaging modality in all patients. It's quick, easy, reproducible, which makes it great for serial examinations. And what can we evaluate on radiographs? We can assess bone loss or erosions if present. The pattern of joint space narrowing, is it uniform in the setting of an inflammatory arthropathy or non-uniform that we see with osteoarthritis? The distribution of involvement, we can look a little bit about bone density. Sometimes we can see it if it's present. Sometimes it can be a little tricky, depends how the film technique is, and the presence or absence of proliferative changes. Next. These are AP views of both ankles. We're looking at the symptomatic right, and the left side is for comparison. And we also have the lateral view of the right on the right-hand side of the screen. We can see in the right ankle, there is non-uniform ankle joint space narrowing, preferentially anterolaterally. We still have a little bit of residual gapping, lucent joint space posteriorly, subchondral sclerosis, and anterior osteophyte formation to define the presence of osteoarthritis. Next. AP and lateral views of the foot in a patient who has midfoot pain. Again, radiographs can help us both define the type of arthritis and where it is. So we can see in the midfoot, if we localize, next slide, that there is bone-on-bone apposition at the talonavicular joint with subchondral sclerosis and dorsal osteophyte formation, with the forefoot and the ankle joints being fairly well maintained. Next. AP view of both feet combined together, looking for comparisons. Sometimes we do this film type if we're looking for Liz Frank injuries. We can see that on the left side, with next slide, please, we can see that there is non-uniform joint space narrowing with subchondral sclerosis, more severe than on the right. Next, lateral view, the same patient where we have dorsal osteophyte formation, soft tissue swelling, and an intracapsular ossific body to define the presence of hallux rigidus. Next, and next slide. This is a different patient. Now we see things look a little different than we've seen before. Now, this is an AP and lateral view of a patient who has a more inflammatory arthropathy. We can appreciate, again, even kind of depending on the film technique, that this patient really does have a little bit of osteopenia. We can see the bones look a little washed out. And looking at the ankle and hindfoot articulations, we can appreciate that there's uniform joint space narrowing in this patient with an inflammatory arthropathy, really not much in the way of bony proliferative changes and soft tissue swelling. Next. There are some limitations to radiographs. There is complicated anatomy, especially in the midfoot. There's lots of overlapping structures. Next slide. We can see in the patient who has midfoot pain that there's osteoarthritis in the second TMT joint, but it's really partially obscured from the adjacent third. We cannot directly visualize articular cartilage, and we cannot evaluate the presence of, and I will call them subclinical erosions. We can imagine, we can kind of extrapolate from bone tumors, right, where you have to have a certain amount of bone that's lost before we're going to see it on an X-ray. Next. So what else do we have available to us to evaluate these patients with arthritis? CT provides better evaluation of the osseous anatomy than radiographs. We can see joint space narrowing, erosions, and osteophytes. Weight-bearing CT, when available, really affords the ability to evaluate the alignment of the foot in a fully loaded position. And Cesar Netto, one of our former fellows who's now at Iowa, really has done a lot of work in terms of the evaluation and use of weight-bearing CT in terms of pre-surgical planning, especially in the setting of progressive collapsing flat foot deformity. And we'll talk a little bit about dual energy CT. Next. Coronal and sagittal weight-bearing images where we can see this patient has osteoarthritis, right? It's pretty bad. Bone-on-bone apposition, anterolaterally, there's subchondral sclerosis, probably a bit of underlying ligamentous insufficiency. We've got some anterior translation of the talus. But more importantly, we can appreciate on the coronal view the marked valgus deformity at the ankle, which would need to be addressed at the time of surgical correction, likely arthroplasty in this patient. Next. Different patient coronal and sagittal CT images. We can see there's really decreased bone mineralization, right? This is more of an inflammatory type picture. In contrast to the case we just looked at, this is more uniform joint space narrowing throughout the ankle, an overall paucity of bony proliferative changes, and we also have a preponderance of subchondral cystic change. Next. Dual energy CT is something useful that we have available to us to detect subclinical gout. So what we can use this for is detecting the urate crystals, and basically two sets of images are obtained. And we take advantage of the fact that urate has a distinct dual energy index, and we can color code it, next slide, so we can really see these. And these color coded images are blended with standard CT images to provide a reference anatomic landmark to localize these areas of abnormality, and has a very high sensitivity and specificity. Next slide. So what does this look like on CT? We can see the first three images are sagittal images marching from central to medial through the hallux MP joint, and then axial image on the bottom right, where we can see sort of that fluorescent green, right, kind of on the medial aspect of the first MTP joint, and that confirms the presence of gout. Next. Ultrasound is quite useful for, as you can imagine, looking at various soft tissue pathologies of arthritis, such as synovitis, joint effusion. Power Doppler is something that pretty much all machines have, which basically indicates the presence or absence of blood flow. There's no directionality like the regular kind of the red and blue that you're used to looking at with Doppler looking for blood flow, arterial or venous. It just is there or it's not, but it's very sensitive, which makes it quite useful in evaluating inflammatory arthropathies, which have increased, blood flow, hyperemia, but it's not so much. There are various groups that have provided standardized definitions and criteria, which are quite useful for outcome studies and following these patients with arthritis. And the OMERAC group, as sure as you all know, has been very helpful in defining these criteria. We can use them for research studies to provide a standardized outcome and what everybody's looking at. Ultrasound has a higher sensitivity for detecting erosions than conventional radiographs, and we can see various soft tissue findings such as rheumatoid nodules. Next. So these are longitudinal images of an arthritic second TMT joint. I'm not sure everyone's kind of used to looking at ultrasound, but we can see that there is deformity at the dorsal aspect of the joint with osteophytes in contrast to the more normal longitudinal bright cortex of the metatarsal shaft to the right of each image. There is hypoechoic inflammatory debris distending the dorsal joint recess, and we can see on the image on the right, when we put on power Doppler, that there is increased blood flow indicating the presence of inflammation. Next. Ultrasound is also quite useful that one can perform diagnostic and or therapeutic injections at the same sitting. We can see that there is inflammation in this patient who has ankle joint arthritis. There is anterior osteophyte formation involved in the tibial plafond and hypoechoic debris and kind of synovial thickening. And we can see in the image on the right, next slide, where the echogenic needle is directed accurately into the joint. So we know exactly where the injection mixture has been dispersed. Next. MRI is the most useful in terms of evaluation of, I would say, everything, kind of a global evaluation. We want to look at the soft tissues, the bones. It's very useful for looking at the presence or absence of synovitis. Various researchers have investigated the use of intravenous or intra-articular contrast administration, the presence or absence of bone marrow edema, which could herald the presence of subclinical erosions and can be used to follow activity of disease. Articular cartilage, we can directly visualize the articular cartilage with high resolution cartilage sensitive pulse sequences. MRI also has many avenues for further detailed investigation of articular cartilage, and we can probably spend a whole other session discussing that in various scientific methods and research applications, such as ultrashort TE, quantitative imaging, T1 row, and T2 mapping. And we can also see other soft tissue abnormalities, such as tendon pathology and bursal collections. Next slide. These are sagittal and coronal fast spin echo images in a patient with rheumatoid arthritis. There is severe, diffuse, uniform thinning of articular cartilage. You can see both the ankle and the subtalar joints are fairly equally affected. There is synovitis both in the ankle and posterior subtalar joint recesses, and there is actual fusion across the midfoot. Next slide. In contrast to this patient, these are coronal and sagittal fast spin echo images in a patient with post-traumatic osteoarthritis. And clearly you can see the difference between the two cases is largely the degree of remodeling of the subchondral bone. Here in osteoarthritis, we have much more subchondral sclerosis and exuberant bony proliferative changes, both involving the medial aspect of the tibia and as well as the distal fibula, probably the latter of which is likely due to a little bit of subfibular impingement. Next. This is an example of a patient with rheumatoid arthritis. We have coronal, sagittal, and axial fast spin echo images where there is inflammatory debris, next slide, about the fifth MTP joint with a subjacent erosion in the lateral aspect of the fifth metatarsal head. Next. We can see small structures of the midfoot and forefoot with MRI. These are two coronal images of the midfoot. Patient was having lateral sided pain. There was some concern for an inflammatory arthropathy. Next slide. We can see there's reactive edema about the fourth and fifth TMT joints, inflammatory synovitis distending the lateral margin of the fifth TMT joint with likely disruption of the lateral joint capsule. And we can see that there's an inflammatory process going on because we are losing the normal low signal intensity cortex of the subchondral plate in the distal aspect of the cuboid, where the inflammatory process is just eating away the bone. Next. So what do these various arthropathies look like on imaging? Well, let's take a couple of examples. Rheumatoid arthritis is still pretty common. We do see it quite a bit. It manifests on radiographs as areas of periarticular osteopenia progressing to kind of full-blown osteoporosis throughout all the osseous structures. Uniform joint space loss, it's a severe inflammatory process, so it's going to eat away the articular cartilage pretty equally. The presence of erosions, it's typically a bilateral symmetric disease. Erosive changes, typically like the fifth metatarsal head in the foot, plantarly and laterally. I'll typically tell our residents and fellows if someone comes by with a curbside consult and wants to know, here's a foot film, does this patient have rheumatoid arthritis? Their eye should directly go to the fifth MTP joint. Synovitis and other soft tissue pathologies, and obviously with the deformities and osteoporosis can ultimately lead to complicating fractures and malalignment. Next slide. These are two different patients demonstrating a similar pathology, AP and oblique views of the foot. Next slide, where we can see focal erosive changes of the fifth metatarsal head. Again, rheumatoid really likes the fifth metatarsal. Next. These are coronal midfoot images in a patient with rheumatoid arthritis. We can see there's multifocal bone marrow edema pattern, cortical bone loss. Again, we're kind of eating away the second intercuneiform joint margins, as well as kind of at the lateral cuneiform cuboid articulation. And then interestingly, we can see in the adjacent tibialis anterior tendon sheath, there are the quote unquote rice bodies that we can see these areas of inflammatory debris in the tendon sheath. Next. Psoriasis is a little more complicated in terms of the radiographic presentation. It's one of those things that can sort of look like one and sort of look like something else and kind of fall in the middle. Typically, it has distal joint involvement as opposed to, say, something like rheumatoid, which can be a little more proximal sometimes, like the midfoot. You can get isolated dactylitis with soft tissue swelling limited to 1 digit, so quote unquote sausage digit. And next slide, the erosive changes and deformity that we can see with psoriasis often yield this quote unquote pencil and cup deformity. Next. Osteoarthritis obviously is kind of the big one. Most of the things we're talking about today is osteoarthritis, non-uniform joint space narrowing, osteophyte formation, sclerosis, and proliferative changes. Really bony proliferative changes are sort of the hallmark for osteoarthritis in contrast to the other arthropathies that we've been talking about. But just as kind of, caveat, things can become a little complicated because you can have a mixed picture, even in something like rheumatoid arthritis, because ultimately, once the cartilage is destroyed and you have bone on bone, you can start getting secondary osteoarthritis and get a little confusing. But next. As we also been talking about this afternoon, it is usually probably near, all the time post-traumatic. Dr. Saltzman has reported on in one series of almost 70% of patients had post-traumatic osteoarthritis versus primary. And other studies have also confirmed this to have patients have had a history of an ankle sprain. Eventually, if you kind of go back in the patient's history, though, they will remember that they had some sort of trauma. And there are various radiographic atlases available to use and evaluate osteoarthritis, which makes it, again, very, very useful for scoring and research purposes in terms of follow-up, standardizing treatment and outcomes measures. Next. These are AP and lateral views of the ankle in a patient who has severe post-traumatic ankle joint osteoarthritis, marked subchondral sclerosis, exuberant bony proliferative changes both anteriorly and posteriorly. Probably if we did flexion extension lateral views, there'd be very, very limited motion at this ankle. Next. And probably, as we'll talk a little bit more in tomorrow's session, this is ultimately what the patients kind of go on to in terms of treatment options. We do a lot of ankle replacement for end-stage arthritis. Next. Gout is defined as monosodium urate crystal deposition in synovial fluid, joints, and soft tissues. It's a little more indolent process than something like rheumatoid arthritis. So you get this classic quote unquote overhanging edge of cortex as the gouty tophus eats away the bone. And the joint spaces are usually maintained until late in the disease. Next slide. Gouty tophi can be seen on MRI. These are coronal and sagittal images where we can see these multiple intermediate signal intensity soft tissue masses centered about the first MTP joint, yes, which we normally associate with gout, but it can occur pretty much anywhere. They say gout is the great mimicker. It's one of those diagnoses where if you don't think about it, sometimes you're not going to come up with it. Next slide. And axial image in the same patient, really identify these areas of mass-like gouty tophi. Next. AP and oblique views of the ankle in a patient with suspected gout. There is a lateral soft tissue mass, and if we really, really look at it, we can see that there's a little bit of high attenuation material in this soft tissue mass, which maybe could be urate crystals. And next slide. We can see there's coronal fast spin echo and axial inversion recovery images. Next slide, confirming the presence of a gouty tophus. Next. Gout in the foot and ankle really, really, really likes the hallux sesamoids. Another sort of radiology tip, sort of differential for quote unquote vanishing sesamoid on x-rays. Either you weren't born with one, which happens, is surgically removed, or it's gout. Next slide. We can see in the medial hallux sesamoid, the medial hallux sesamoid, first of all, is almost twice the size, right, as the lateral. So something is infiltrating into the sesamoid. It's high signal, little high signal on inversion recovery. It has a little bit of texture to it, intermediate signal intensity on the other sequences. And if we really, really look, we see these punctate areas of low signal intensity for the calcifications or sort of mineralization associated with the gouty tophus. Next. The European League Against Rheumatism has come out with evidence-based recommendations for the diagnosis of gout. These are their two imaging-centric recommendations, both of which are grade A recommendations. Next slide. And the one that I do want to highlight is the double contour sign at ultrasound. Next. This is a longitudinal image of the first MTP joint. The metatarsal head is to your left and the base of the proximal phalanx is to your right. We can see again the surface of the echogenic bright cortices of the bone. Typically, articular cartilage is decreased echogenicity or dark. And what you have is, next slide, this very, very thin hyperechoic bright layer sort of outlining the articular cartilage over the first metatarsal head, which is the deposition of these echogenic monosodium urate crystals on the surface of the contrasting lower echogenicity hyaline cartilage. And this is the double contour sign in gout. Next. So in summary, there are a plethora of imaging modalities available to evaluate, treat, and follow patients with arthritis. Next. Radiographs certainly remain the mainstay of imaging. Next. CT is better used to delineate erosions and cysts, and it's often used in the setting of pre-surgical evaluation, whether you're going to do an arthroplasty or other additional bony work or possibly go on to a fusion. Next. Ultrasound can accurately evaluate the soft tissues. There is no radiation, and you can perform diagnostic and therapeutic injections at the same sitting. Next. And MRI kind of provides your overall global evaluation of bone, soft tissue, and articular cartilage. Next, that's it. Thank you for your attention.